So can we have our first speaker, Dr. Srinivas? Let's start this session. Our panelists will join soon. We'll calling them from outside.
Once again, thank you, Dr. Raju Ishwaran, Dr. Shekhar Srivastava, Dr. Himanshu, Dr. Ankit and team for the opportunity. This time I have an unusual posterior septum lesion and I will present how I managed it. A 15-year-old adolescent girl with hypothyroid presented to me with acute onset of knee pain that persisted for 40 days duration. There was no obvious direct trauma, but she does report that she fell from a bike as she was a pillion rider sitting at the back of a bike. A few days before the symptoms started, she walked normally after the fall. She consulted elsewhere before she came to me and was investigated along the lines of acute infection, tuberculosis of the knee because of the type of presentation. A total white cell count of 1,500 with an ESR of 98 in the first 1 hour indicated inflammation or infection. This was 1 month before she presented to me and 10 days after the onset of symptoms. She does give one episode of fever. After she came to me, the ESR reduced to 18 millimeters. This is at 40 days. And she had a fixed flexion deformity of 30 degrees and further flexion was possible only up to 60 degrees. She also had a small effusion in the knee. She was extremely tender posteriorly in the popliteal fossa. There was no distal neurovascular deficit. So this was a plain radiograph taken by the previous consultant. There was no bony pathology as such seen in this radiograph. After she came to me, I performed an MRI scan. The images in this plain MRI of the knee showed an ill-defined lesion in the posterior septum of the knee. And there is bone marrow edema in the adjacent medial femoral condyle, as you can see. We also did a contrast MRI to find out the exact the type of pathology. It showed increased signal within the lesion and the surrounding area of the posterior septum.
Srinivas sir, infection profile was normal in this case.
When she came to me, the infection profile was normal. ESR was very low, white cell count was within normal range. She was apyrexial, and apart from the tenderness posteriorly, she had a pain-free range of movement from the fixed flexion 30 degrees to 60 degrees, and the extremes were very painful. So these are the sagittal sections, and these are the transverse sections. As you can see, there's a increased glow in the within the lesion and the surrounding area with increased contrast uptake. So ARS1, what is the possible etiology of this lesion? Acute or subacute sepsis, tuberculosis, traumatic or neoplastic? The main challenge here was to find out the etiology of this because we were not sure what exactly the problem is.
Can we have the ARS question on now? Yes.
So a possible acute or subacute sepsis. And how can one manage this lesion? This is the second question. Based on your assessment, conservative with antibiotics, open excision, arthroscopic excision, or arthroscopic and open excision.
So before we talk about this question, can we have some other test to diagnose this lesion apart from MRI?
I did perform the contrast MRI to see how it enhances. So clinically and with MRI scan, it looks like it is localized within the posterior septum. It's probably not extending beyond that. And there is some increased uptake within the medial femoral condyle.
So any role of ultrasound guided aspiration or something?
No, there was an attempted aspiration. I actually did it in the theater, within the theater, before I did, I decided to do the
Sameer sir.
So Srinivas sir, would you contemplate doing a PET CT for this to see the uptake? Is it an active, evolving?
I did discuss with the radiologist. We felt it's probably not infective, So what we did was do the contrast MRI scan. Clinically and with the MRI, we felt there is a localized lesion within the posterior septum. It didn't look malignant, no, not neoplastic. Maybe a contained infection, that's what I felt, and I went into the knee, did an arthroscopy to...
Dr. In terms of literature, what does it say in terms of most common causes? What are the causes from one to last?
In the posterior septum, there is nothing reported.
So this could be some kind of a localized hematoma or some kind of
Yeah,
sterile
no
collection on the
traumatic,
backside.
what I knew.
There was no case reported in the posterior septum in the literature before this.
Sir,
Okay.
one question. So, is it a possibility of synovial chondromatosis?
Yep.
My case report will be coming online. I will share with that you. But exactly same lesion, exactly same site, encapsulated. Although in your MRI it was not that encapsulated. It's more of a diffuse edema kind of a thing. But exactly the same site came out histopathologically to be a synovial chondromatosis.
Would it explain the increase in contrast uptake and the adjacent medial femoral condyle?
Yeah, that is one thing that has to be kept, that widens the differential diagnosis.
And also
definitely,
her
yes.
symptoms before, they look more like an acute problem rather than a chronic issue with her symptoms and the MRI presentation.
More or less similar symptoms in our case. Posterior pain and was not a chronic pain developed over the past 1 month. Then they presented to us, and then we did the MRI. Probably the reason was it increased to the size when it started impinging on the capsule that much that it started causing discomfort.
So let's see what ARS said for this. So
Can
can we have the results of this ARS? It's already done? Yeah. This is arthroscopic excision.
Okay, so I put this is what I felt. So these are the images in arthroscopy. I'll go through the video in detail. We did publish this in JBJS Case Connect. We excised the lesion and sent for histopathology, which confirmed the lesion as a heterotopic ossification within the posterior septum. So this is the plan of the technique used. 3 portals, anterolateral for the grasper, anteromedial for the scope, and posteromedial for the trocar and the shaver to push the lesion and support the lesion and clear it for removal. So this is a video. Anteriorly, it looked normal. So I'm clearing the tissue lateral to the PCL to access the posterior septum. So as soon as I put the trocar in the posterior septum, you can see a gush of blood coming out. So there's absolutely no pus that came out. So it looked more like a traumatic origin. Creating the posteromedial portal. So that is the lesion within the septum. So I introduce the grasper through the anterolateral portal, the trocar through the posteromedial portal, and the scope is in the anteromedial portal. While trying to grasp the lesion with the grasper within the septum, it was actually loosely attached to the tissue within the posterior septum, so it was not, I'm not getting a hold into the lesion, so I had to push it using the trocar from the posteromedial portal to try a grip and get a grip onto this lesion. And it's very friable. The outer bone was like an eggshell, very friable, and it broke very easily. So I had to remove it piecemeal, initially through the anterolateral portal using the grasper, and later through the posteromedial portal to remove any remnants of this lesion. So that's the final picture after removal of the lesion. So on arthroscopy, we took synovial fluid and sent the lesion for histopathology. This is the histopathology. It showed evidence of heterotopic ossification. There are multifocal areas of osteoid formation with intervening cancellous bone and fibrous stroma. The peripheral area showed woven bone and compressed fibrous pseudocapsule. The granulation tissue like spindle cell proliferation was seen without bone formation. That was also partly seen. So postoperatively, I put her on oral indomethacin 25 milligrams thrice daily for 6 weeks. And so in the literature, access to posterior septum is the key here. There were only in the English literature, only 2 cases were reported. One was a ganglion in the posterior septum, which was handled through a trans-notch portal. And the other case was a broken tension band wire for a patellar fracture, and which migrated to the septum. And this was removed using a posteromedial transseptal portal. No heterotopic ossification was reported in the septum before, and no dual portal technique was reported. So HO is defined as formation of bone in tissues that normally exhibit no properties of ossification. So it's a result of a complex interplay between the cells arising either from the damaged tissue or from the circulation after trauma or inflammation. And factors are released which promote neovascularization, endothelial cells, and to form bone. And HO differs from bone formation, but the pathways between both formation and heterotopic ossification are similar. So patient is now 4 years post-op. She became symptom-free 4 weeks after the surgery and remained symptom-free without any recurrences till now. She went back to normal activities 6 weeks after the surgery.
That's indeed a rare presentation of heterotrophic ossification in posterior compartment. Anybody having any experience of such kind of lesion? Anywhere else in the knee? But sir, what made you think that you just go and scope this thing before taking any biopsy? This could have been a big problem if something turned into a tumor at this level.
I have had a discussion with the radiologist. They felt it did not look like a tumor. It's a benign lesion with a surrounding increased uptake. And if you can see, looking back after excision, if you can get this slide on, please. So if you can see here, there is increased bone marrow edema within the medial femoral condyle. And the lesion is very close to that, possibly a PCL, partial avulsion type of injury that released bone-forming cells within the posterior septum, and that has caused formation of HO.
Yes, Dr. Suneet.
Usually we do not, in the X-ray we could not see any bone formation actually. So it was a very early stage of HO where the bone formation was still not that large.
The X-ray was done earlier, I think within 7 to 10 days.
We usually excise the HO only after the maturity. So if we do not excise the HO after maturity, the chances of the recurrence is far more higher. Do you think that since this was probably done prematurely, then chances of further ossification or further HO formation might increase?
By the time she came to me, it was almost 1.5 months, and the knee was relatively quiet. ESR had settled down. She was painful, but perhaps at by that stage, everything has quietened a little bit. It's not, maybe not classically like the myositis ossificans where we do at 3-month stage, but this one I felt probably was adequate. Yes, yeah.
Any more questions on this?
Just a small one. Heterotopic ossification on histopathology or heterotopic calcification on histopathology? There's a bit difference in the, and only the pathologist can tell. But that decides how much is going to go forward and where to stop.
The appearance was osteoid, so it's ossification. more than calcification.
Thank you, Dr. Srinivas.